Tubercular and fungal infections of the spine. Dr. G.R. The human spine has three principal functions: balancing the trunk during standing, which we can think of as static stability; stabilizing the trunk during activity, which we can think of as dynamic stability; and protecting the neural elements. Infections of the spine can affect all these functions and can be associated with significant morbidity. Although less common than pyogenic infections, fungal and tubercular infections of the spine can be extremely destructive, lead to spinal instability, neural compression, and even death. The initial diagnosis of these infections is often delayed because of an insidious onset with nonspecific symptoms, absence of specific and sensitive blood tests, and absence of changes on conventional radiography in the early stages. Thus, often at diagnosis, there is significant bony destruction with instability and neural compression with associated neurological deficits. Although relatively less common in the developed countries, tuberculosis has demonstrated a resurgence because of the human immunodeficiency virus epidemic, greater use of broad-spectrum antibiotics, and widespread use of indwelling catheters and lines. Spinal tuberculosis. Hippocrates in 450 BC is credited with the first Western description of TB of the spine, and he described gibbosity above and below the diaphragm. However, TB has been known to be in existence as an infectious disease as far back as 4000 BC, with features of spinal tuberculosis having been noted in Egyptian mummies dating back to that period. The Greco-Roman civilization recognized the condition as phthisis or consumption. In India, it is mentioned in the Vedas, the Rig Veda and the Atharva Veda, dating back to 3500 BC to 1800 BC as yakshma, with descriptions of many forms of the disease. Sir Percival Pott described tuberculous paraplegia in 1779 as that kind of palsy of lower limbs which is frequently found to accompany a curvature of the spine. The basic microscopic lesion, which was called the tubercle by René Laennec, a French physician in 1819, and has been the basis of the name by which the disease is now known universally. Laennec was also incidentally the inventor of the clinical stethoscope. The next advancement of note was the identification of Mycobacterium as the causative organism of tuberculosis by Robert Koch in 1870. Another advance was the introduction of the BCG, or the Bacillus calmette-guerin vaccination, in 1945. Before the advent of chemotherapy, the natural history of skeletal TB comprised three stages spanning 3 to 5 years. In the stage of onset, lasting up to 1 year, there was localized disease manifesting as a tender swelling with minimal destruction. In the next stage of destruction, there was gross destruction of bones and joints with abscess and draining sinus formation and secondary infection. This phase, lasting for 1 to 3 years, had a high mortality from miliary spread, meningitis, secondary infections, and cachexia. The survivors entered the stage of repair and ankylosis with healing of sinuses, resolution of abscesses, and fusion of the disease bone in deformity. A major milestone in the war against tuberculosis was the introduction of anti-tubercular drugs in the years between 1947 and 1952. Streptomycin became available for clinical use in 1947, followed by para-aminosalicylic acid in 1949 and isoniazid in 1952. Tuberculosis is and has been one of the leading causes of death in the world. Globally, in 2017, an estimated 10 million people developed TB, of which 5.8 million men, 3.2 million women, and 1 million were children. The estimated deaths due to TB are 1.3 million in HIV-negative individuals and a further 0.3 million deaths in HIV-positive individuals. Of the global TB burden, 46.5% is contributed by the Southeast Asian region compared to 3% from the European region. TB remains in the top 10 leading causes of death, even above HIV and AIDS in sheer numbers, despite a 22% drop in mortality from tuberculosis between the years of 2000 to 2015. Tuberculosis commonly affects the lung. The incidence of extrapulmonary tuberculosis varies from 4% as described in Indonesia to 39% as described in Australia, and is thought to be higher in countries with a lower incidence of TB. The factors attributed to this variation in incidence are thought to be the prevalence of HIV infection, access to better investigation and diagnostic facilities in developed nations, and the low infectivity of extrapulmonary tuberculosis. About 10% of patients with extrapulmonary TB have skeletal involvement, and half of these patients have involvement of the spine. The incidence of skeletal TB is much higher in HIV-positive patients. As a result of the spread of HIV and the associated acquired immunodeficiency syndrome, in some African countries, the number of reported TB cases has doubled or even tripled. The emergence of AIDS has also increased the incidence of disseminated Mycobacterium avium complex infection. This occurs almost exclusively in patients with a CD4 lymphocyte count below 100. There has also been an associated rise in the development of multi-drug resistant variants of TB associated with this resurgence. Migration is another factor in the dissemination of TB across the globe. Migration tends to happen from low and middle income countries with a higher incidence of TB to high income nations with a lower prevalence of TB. The United Nations has reported the international migrant population as 244 million in 2015, up from 191 million in 2005. The WHO has promulgated the End TB strategy in 2015 because TB is a focus disease for the World Health Organization. The idea is to reduce TB deaths by 90% and TB incidence rates by 80% by the year 2030, and this is to be adopted by all member nations of the World Health Organization. Pathophysiology of spinal tuberculosis. The genus Mycobacterium comprises of around 60 different species, of which 2 are strict pathogens that afflict humans: Mycobacterium tuberculosis, causative organism of tuberculosis, and Mycobacterium leprae, causing leprosy. Mycobacterium tuberculosis, the causative organism of TB, is an aerobic, slow-growing, acid-fast bacillus which multiplies every 15 to 20 hours in a favorable aerobic environment. It can remain dormant for prolonged periods and can have a resurgence or burst of activity once the conditions are favorable. Spinal involvement in tuberculosis is always secondary, with the primary infection usually being the lungs through inhalation. Other common primary sites are the lymph nodes, urogenital system, and the gastrointestinal tract. The infection then spreads throughout the body via the bloodstream. The bacillus has the ability to remain dormant for years, multiplying when conditions are favorable. Because of their vascularity, the vertebral bodies are particularly at risk for infection from disseminated tuberculosis. The lower thoracic spine is most commonly affected in TB, followed by the lumbar and cervical spine. Hematogenous spread can be through the arterial or venous circulation. The venous dissemination is postulated via the batsons and the retropharyngeal venous plexuses. The arterial dissemination may explain the difference in the type of infection seen in adults and in children. In children, a discitis occurs due to inoculation into the persisting vascular channels in the disc, whereas the relatively avascular disc in adults leads to a subchondral infection initially with later involvement of the disc space. Different patterns of vertebral involvement are described based on the affected anatomy as paradiscal, where there is subchondral bony involvement, anterior subperiosteal, central, where there is bone loss in the vertebral body, appendiceal, where there is posterior element involvement, and non-osseous abscess. The paradiscal type is the most frequent pattern noted in adults. The hallmark of TB is granulomatous inflammation. Histologically, the granuloma has a central necrotic core surrounded by concentric layers of macrophages, epithelioid cells, Langerhans giant cells, and leukocytes. The granuloma is thought to be an immune response mounted by the host to contain the tubercle bacillus and prevent active infection. This process is successful in over 90% of individuals, leading to a latent infection as evidenced by quiescent calcified granulomata. Compromised T-cell mediated cellular immunity in particular has been suggested to be important in mycobacterial infection. It is thought that an imbalance between the helper and suppressor T cells is involved in the pathogenesis of TB in humans. It is also known that the helper-suppressor T cell ratio in extrapulmonary TB is lower than that in pulmonary TB. As with pulmonary tuberculosis, spinal TB also has a close association with socioeconomic factors and endemic exposure. The disease is more common in Asia, Africa, and South America. In these countries, spinal TB more commonly affects the young, usually in the first 3 decades of life. Half of all those affected are in the first decade, and only 1/4 are older than 20 years. However, in the Western world, the disease most commonly affects adults. More recently, a second peak is being noted in individuals over than 60 years, even in developed nations. This has been attributed to an increased life expectancy, diabetes, immune suppression, and other factors. Tubercular spondylitis has an insidious onset, which differentiates it from pyogenic spondylodiscitis. The average duration from onset of symptoms to diagnosis is reported to be 4 months, but can be considerably longer, especially in patients from lower socioeconomic strata. The most common presenting symptom is local pain, which is often present for weeks or months. Infection may be associated with paravertebral muscle spasm, and rigidity. The back pain is presumed to be caused by local inflammation. At a later stage, there may be bony collapse and segmental instability causing pain. Constitutional symptoms of malaise, anorexia, weight loss, and fever are classically described. However, constitutional symptoms are more often associated with pulmonary TB and are present in less than half the patients with spinal TB. Nocturnal rise in body temperature and night sweats are more often present in spinal TB. Paravertebral collections or abscesses are seen in 50% of patients with spinal TB. Unlike a pyogenic abscess, a tubercular abscess does not always exhibit the classical features of rubor, dolor, and calor, and is commonly referred to as a cold abscess. A cold abscess is a well-defined fluctuant swelling. It may be warm and slightly tender. The overlying skin, which is often stretched and shiny, may burst and develop into a draining sinus. The discharge varies in color from white to yellow and in consistency from watery to thick caseous material. Sometimes secondary infection may occur in a tubercular abscess, and these patients may have all the features of a pyogenic abscess. The tubercular abscess commences at the site of the infective focus. However, as it expands, it slowly dissects through the surrounding tissue and spreads along natural tissue planes like the muscle sheaths, perineurium, and perivascular planes. Thus, a spinal infective focus can produce a paravertebral abscess that can then track along the muscle planes to produce a psoas abscess, along the sciatic nerve to present in the gluteal region, and along the aorta and the femoral artery to present in the femoral triangle. Occasionally, the abscess may be quite distant from the infective focus, leading to diagnostic errors. Spinal tuberculosis may present with deformity. Deformity may develop as a consequence of vertebral destruction in the acute phase of the disease or as a consequence of surgical treatment. In children, deformity can occur even after the healing of the disease focus because of normal growth. The infection preferentially affects the anterior column of the spine in 90% of patients. As the infection progresses, there is destruction of the vertebral body. In paradiscal lesions, there is early destruction of the intervening disc, which can lead to spontaneous fusion. With more severe disease, there is destruction of one or more entire vertebral segments, leading to kyphotic deformity, which can gradually increase with time. The deformity produced is varyingly described as a knuckle deformity when one vertebral segment collapses, as a gibbous deformity when 2 or 3 segments collapse, and as an angular kyphosis when there are more than 3 segments of collapse. However, in adults, when the lumbar spine is involved, the pattern of vertebral collapse is different from that of the dorsolumbar spine and is telescoping in nature. The incidence of neurological deficits in patients at presentation varies from 10% to 40% in different studies. Patients often also present late after the appearance of a neurological deficit, with only 33% reporting within 4 weeks of appearance of a neurological deficit in a study by Tully. The neurological deficits can range from subtle gait disturbance to complete paraplegia with sphincter involvement. The neurological deficits occurring in spinal TB have traditionally been classified as early onset, which occur during the active phase of the disease, typically during the first 2 years, and late onset, which can occur many years later and even after successful treatment of the acute phase of the disease. In the active disease phase, neurological deficits are thought to be produced by extrinsic compression of the spinal cord or nerve roots by the abscess or granulation tissue, bony compression, or dislocation of the vertebrae. Neurological deficits may also be produced by intrinsic infection of the spinal cord from meningeal infection, intramedullary infection, inflammatory edema, or spinal cord infarction due to endarteritis or infective thrombosis in the spinal vessels. Late onset neurological deficits are likely caused by repetitive trauma from bony compression, as in the case of an internal gibbus, constrictive scarring of the dura, or due to disease reactivation. Often, the kyphotic deformity can result in neurological deficit, and in this case is attributed to cord compression, cord distraction, stenosis, and instability above or below the level of the angular kyphosis. Classical descriptions of TB infection depict a malnourished patient from a poor socioeconomic background with pulmonary involvement. However, this scenario may no longer be applicable because a significant number of patients with TB infection are well nourished and financially well-to-do. TB is a systemic disease and can affect multiple spinal segments simultaneously. The affected segments may be contiguous, or there may be single or multiple intervening segments between the affected segments. The presenting signs and symptoms are usually related to one of the affected segments. The incidence of multicentric TB is stated to be 20 to 24%, and multicentric TB is likely to have a higher risk for associated morbidity, including deformity, instability, and neurological deficit. The posterior elements may be affected in 0.2 to 10% of patients. The lamina is most commonly affected, followed by the pedicles, the spinous process, and the transverse process. Neurological deficits result from compression of the spinal cord and nerve roots. Radiographic abnormalities are difficult to identify, and the lesion is usually identified on MRI. Intradural and intramedullary tuberculomas present with progressive neurological deficit. They are very difficult to distinguish from neoplasia. The possibility should be kept in mind in TB endemic countries when the presentation is unusual for tumor and in the presence of arachnoiditis. In children, a discitis occurs due to inoculation into the persisting vascular channels in the disc, whereas the relatively avascular disc in adults leads to a subchondral infection initially with later involvement of the disc space. Pediatric patients also have more extensive vertebral body bone destruction, leading to greater deformity at presentation, greater progression of deformity during the active phase of the disease, and variable continued progression even after successful treatment of the acute phase of the disease. This has been attributed to variable destruction and suppression of the vertebral growth plates by the disease process. The most conclusive method of establishing a diagnosis in spinal TB is demonstration of acid-fast bacilli by smear or culture or by histopathologic examination. This necessitates an invasive procedure. Fine needle aspiration cytology is unfortunately not as effective in diagnosing spinal TB as it is in TB lymphadenitis. In patients warranting a surgical procedure for neural decompression or spinal stabilization, tissue can be collected at the time of surgery. However, in most instances, tissue is preferably collected in a percutaneous manner using a wide-bore core biopsy needle such as the Jamshidi or the Cook needle. This can be done through a transpedicular or the posterolateral approach under fluoroscopy or CT guidance. Both imaging techniques have similar accuracy, but it may be preferable to perform the procedure in the operating room. The procedure is usually done under local anesthesia with sedation if required. Cold abscesses can be aspirated for diagnosis deep-seated abscesses can be aspirated under ultrasound or CT guidance. Tissue collected can be sent for smear and staining, histopathology, culture and sensitivity, and polymerase chain reaction. Radiographs demonstrate vertebral body osteolysis and kyphosis due to bone destruction. However, it can take up to 3 to 4 months for spinal TB lesions to show up on plain radiographs, and hence they are not useful in the early diagnosis of spinal TB. Chest X-ray should be done routinely in all patients with spine TB, since 60 to 70% of patients will also have pulmonary lesions. Plain X-rays are also of use in assessing spinal alignment, classifying the extent of deformity, and for ruling out other pathology. Bony lesions can also be assessed by computed tomography, which demonstrates the location and extent of vertebral involvement much earlier than radiographs. 4 patterns of vertebral involvement have been described based on CT appearances as fragmentary, osteolytic, subperiosteal, and localized sclerosis in decreasing order of frequency. CT with contrast will delineate rim-enhancing abscess cavities, enhancing granulomatous lesions both in bone and in paraspinal soft tissue. CT is also useful for obtaining CT-guided biopsy from the lesion, preferably done with a core biopsy needle rather than fine needle aspiration. MRI has the best sensitivity and specificity for diagnosing spinal tuberculosis. Classical findings on MRI include the presence of marrow edema, disc space preservation, subligamentous extension of abscess, paravertebral septate abscess, epidural extension, end plate erosions, and discitis. Increasing size of an epidural abscess on MRI was associated with a poorer prognosis for neurological recovery. MRI can delineate both bony and paraspinal lesions and identify features of spinal cord meningeal involvement, which include continuous meningeal thickening, secondary arachnoid cyst, and rough and moniliform cerebrospinal fluid spinal cord interface. Other advantages of MRI are that the whole spine can be screened to identify skip lesions and that therapeutic response can be monitored. Fluorodeoxyglucose, positron emission tomography, and PET-CT are newer modalities that have the potential for earlier diagnosis of spinal TB and possible differentiation of tuberculosis from malignancy, and also for assessing ongoing response to treatment. Although all these modalities, either singly or combined, can strongly suggest spinal TB, histopathological confirmation remains a gold standard both for diagnosing tuberculosis and for ruling out other pathology. Routine blood tests may show an elevated erythrocyte sedimentation rate over 20 mm per hour in 60 to 95% of patients. The ESR can also be used to monitor therapeutic response with failure to normalize within 3 months or renewed elevation after an initial fall, raising the suspicion for drug resistance. The ESR, although relatively sensitive, lacks specificity and can be elevated in any infection or even some malignancies. C-reactive protein is also elevated in more than 70% of patients. It is slightly more specific for infections and is slightly quicker at 2 weeks to register changes compared with the ESR, which can take up to 4 weeks to change. The Mantoux tuberculin skin testing is positive in up to 91% of immune-competent patients. However, it may be negative in some immunocompetent patients, in many immunocompromised individuals, and in patients with miliary tuberculosis. It may also not be useful in countries where BCG vaccination is routine. Serological tests using enzyme-linked immunosorbent assay are available to test for the presence of an antibody response to various TB-specific antigens such as A60, CFP21, ESAT6, MPT63, and MPT64. Immunological tests to measure the level of interferon gamma produced in response to mycobacterial antigen are available as in-tube assays. Their sensitivity and specificity are variable depending on the type of fluid sample. They are also unable to differentiate between latent and active infections. The World Health Organization recommends banning unproven and inaccurate blood tests and favors the routine use of more accurate molecular and microbiological tests. Recent advances in molecular diagnostic testing such as PCR and genotyping have enabled quicker diagnosis, differentiation between typical and atypical mycobacteria, and the ability to identify drug resistance. Nucleic acid amplification techniques are used to identify specific mycobacterial target genes and can also be used for species-specific identification. The reported sensitivity is 60 to 75% and specificity is 94 to 100% in extrapulmonary tuberculosis. The GeneXpert MTB and the GeneXpert Ultra can provide a result in 90 minutes and has a high sensitivity and specificity, especially for extrapulmonary tuberculosis. It can also identify rifampicin resistance. And the WHO in March 2017 has recommended the use of the next generation Expert MTB assays as it has better detection rates in all types of TB, including extrapulmonary tuberculosis. Tissue collected can be sent for smear and staining, histopathology, culture and sensitivity, and PCR. Smear examination with ZN staining for AFB is positive in only 12 to 35% of cases. The most commonly used culture medium is LJ medium, an egg-based medium with positive TB detection rates of 0 to 75%. Because TB is paucibacillary, it has lower culture positivity rates compared with pulmonary TB. The major disadvantage of LJ medium is the prolonged time taken for identifying growth. It takes about 6 weeks, and the fact that drug sensitivity can be carried out only after the initial growth. More rapid detection of growth is possible with the BACTEC system and its variants, which rely on the metabolism of carbon-14 labeled palmitic acid, leading to carbon-14 labeled carbon dioxide, which is quantified using specific technology. In comparative studies, the detection rates with BACTEC are comparable and often better than with the conventional LJ medium, and also give the results much earlier. Histopathologically, caseating granulomas and epithelioid cells are characteristic of TB. The test is positive in 62 to 92% of cases and takes 7 to 10 days, making it faster and more accurate than a culture. However, histopathology is unable to identify drug resistance and is primarily used to rule out non-infectious pathologies such as neoplasia. In summary, spinal tuberculosis is diagnosed by correlating the clinical picture with CT and MRI findings and ideally confirmed by demonstrating Mycobacterium tuberculosis in microscopy, culture, or PCR. The principles of drug therapy in spinal tuberculosis are based on our understanding of the causative organism. M. tuberculosis is a slow-growing, strict anaerobe thriving best in an oxygen-rich environment like in the lung. In the spine, the colonies are paucibacillary due to lesser oxygen tension. Most standard antibiotics are ineffective in TB because of the special architecture of the mycobacterial cell wall. Within a TB colony, there are different types of bacteria: extracellular rapidly dividing, extracellular slowly dividing, intracellular slowly dividing, and dormant type. Anti-tubercular drugs act differently on the different types of bacteria. Isoniazid, streptomycin, and ethambutol work best against the extracellular rapidly dividing bacteria, whereas rifampicin is effective against the slowly dividing extracellular ones. Pyrazinamide has the ability to penetrate the macrophages and kill intracellular bacteria, but no drug is effective against the dormant bacteria. These dormant bacteria can remain inactive for prolonged periods of time and can cause a relapse by activation when circumstances are favorable. Treatment with multiple drugs simultaneously is essential to address the different types of bacteria and to prevent the emergence of resistant strains. As in pulmonary TB, the mainstay of treatment of spinal TB is multi-drug antituberculous therapy. The antitubercular drugs are broadly classified into first-line and second-line agents. INH, rifampicin, pyrazinamide, ethambutol, and streptomycin are the first-line drugs. Kanamycin, amikacin, cycloserine, capreomycin, ethionamide, prothionamide, quinolones, and paraaminosalicylic acid are the second-line drugs. The first-line drugs are the most effective agents against TB. The second-line drugs are less effective, have more side effects, and are more expensive, and are used usually for the treatment of drug-resistant TB and in patients with intolerance to first-line agents. The World Health Organization has categorized the types of TB and recommended standard treatment regimes based on the category. The WHO has classified spinal TB as a severe form of extrapulmonary tuberculosis, and it is included in Category 1. The standard treatment for Category 1 has an intensive phase of 2 months when 4 to 5 drugs are given to reduce the bacterial load rapidly, followed by a continuation phase comprising of 2 drugs being administered for 4 months. The duration of treatment in spinal TB continues to be debated. Although the WHO recommends 6 months of treatment, other authorities suggest that 9 or even 12 months duration may be more appropriate. An effective regimen for treatment of spinal TB must cure the patient, prevent the development of drug resistance, and prevent relapse. In addition, in patients with associated pulmonary TB, prevention of disease transmission to others is also an important goal. The medical treatment of TB faces a number of challenges because of the cost of the medication, side effects, and poor compliance owing to the required length of treatment, particularly in developing nations. The occurrence of strains of TB resistant to one or more antitubercular agents can be primary, but is more commonly the result of inadequate or incomplete treatment. Multi-drug resistant TB is the presence of resistance to isoniazid and rifampicin. Extensively drug-resistant TB is the presence of resistance to INH and rifampicin and resistance to any fluoroquinolone and at least one injectable second-line agent. The WHO estimates that the incidence of MDR-TB was 500,000 in 2017, of whom roughly 50,000 patients had XDR-TB. Of concern is the observation that pooled success rates of treatment are 60% for MDR-TB and 26% only for XDR-TB. Such patients should always be referred to or be treated in consultation with an experienced infectious disease specialist. The current treatment of spinal TB is primarily medical. Surgical intervention is an adjunct in selected patients. Successful management of spinal TB hinges on early diagnosis and appropriate chemotherapy before the development of neurological deficits or deformity. Surgery has been advocated for debridement, for decompression of neural elements, and for the prevention and correction of deformity. The goals of surgical treatment in spinal TB are to drain abscesses, remove infected bone, obtain tissue for microbiological and histopathological studies, decompress neural structures, correct deformity, prevent deformity progression, and permit early ambulation and rehabilitation. The surgery can be performed through an anterior approach, a posterior approach, a combined anterior and posterior approach, and by using minimal access techniques. Traditionally, anterior surgical approaches have been proposed for spinal TB. This would appear rational in view of the fact that the anterior column is affected in 90% of patients. The anterior approach offers direct access to the diseased vertebral bodies for drainage of abscess and debridement, allows thorough spinal cord decompression without spinal cord manipulation, enables reconstruction of the anterior column by insertion of a graft or cage, and provides a large surface area for fusion. The anterior approach does have a number of limitations. In the thoracic spine, anterior approaches have a high morbidity in malnourished patients and require specialized equipment and intensive care facilities. Anterior access is anatomically difficult in the upper thoracic spine owing to the presence of the sternum and the vascular structures, and in the lumbosacral spine because of the iliac crest and the iliac vessels. Anterior instrumentation may not have as good a purchase in the often osteoporotic bone of TB patients. Posterior surgical approaches have gained popularity because of their ease of use, low morbidity, and biomechanical strength. Improved implant technology now permits anterior column reconstruction through posterolateral approaches to the thoracic, thoracolumbar, and lumbar spine. Through posterior or posterolateral approach, an anterior debridement can be done by the transpedicular or extracavitary route or by wide bilateral costotransversectomy approaches. Recent studies comparing anterior and posterior approaches have shown that both are equally good to attain good results for correction of deformity, clearance of disease focus, and spinal cord decompression and pain relief. However, the posterior approaches may be superior to anterior instrumentation, especially for correction of deformity and for maintenance of correction. While global reconstruction through a posterior alone approach is now feasible in the majority of cases, there still remains a place for combined anterior and posterior surgery, either in a single sitting or as a staged procedure. Multiple contiguous vertebral body involvement, severe kyphotic deformity, ventral neural compression, severe osteoporosis, and late deformities are the usual indications. The anterior surgery can accomplish good debridement, decompression of the neural structures, and establish anterior column support by a graft or cage, while the posterior surgery can correct and maintain alignment and protect the anterior graft or cage. However, the procedures can have significant morbidity, particularly in the debilitated TB patient. Minimally invasive spine surgery techniques are increasingly being used for the treatment of spinal TB. These include thoracoscopic debridement, drainage of abscesses, anterior instrumentation, percutaneous pedicle screw fixations, transforaminal decompressions and fixations. The MIS techniques can be used alone or in conjunction with part open procedures. While there is concern about the steep learning curve and the efficacy in the presence of multiple vertebral involvement and major deformity, the utilization of MIS techniques is likely to grow with continuing improvements in instrumentation and implant technology. Fungal infections of the spine. Although fungal infections of the spine have been described in immunocompetent individuals, the usual patient is immunocompromised, and the increased incidence of fungal infections is thought to be due in part to the greater use of immunosuppressive drugs, widespread use of broad-spectrum antibiotics, use of indwelling catheters, increasing use of intravenous therapy, central parenteral nutrition, surgery, and hemodialysis, as well as the prevalence of AIDS. Fungal infections of the spine are uncommon. The most common route is through hematogenous spread from another source, usually the lungs. Other routes of infection include direct spread from other organs and from contamination, for example, at the time of surgery. Delay in diagnosis is common and has been shown to lead to worse patient outcomes. Candida organisms, commonly found in normal skin flora and within the gastrointestinal tract, can also exist in the sputum, female genital tract, and the urine of patients with indwelling catheters. Vertebral osteomyelitis is the most common form of fungal bone infection. Of all the pathogenic Candida, Candida albicans is the most common organism to be involved in vertebral osteomyelitis. Other species involved are Candida tropicalis and Candida glabrata. Increased use of azole group of antifungal agents seems to have contributed to the increased incidence of candidal infections in spine. The lower thoracic and lumbar regions are most commonly involved, and usually the initial complaint is of back pain. Aspergillus organisms, typically found in water, soil, decaying vegetation, hay, and grains, are a ubiquitous fungus that creates small spores. These spores are inhaled and cause infection of the alveoli with subsequent hematogenous spread. The vertebral body is the most common site of skeletal infection, although skeletal infection from disseminated Aspergillus species is rare. Usually, it takes months before the diagnosis is established. Aspergillus fumigatus is the most common species isolated in human infection. The disseminated form occurs usually in patients with AIDS, patients with chronic granulomatous disease, long-term antibiotic users, and intravenous drug abusers. Cryptococcus neoformans, found in pigeon feces and in the soil, is the fourth most common infection in patients with HIV and is found in 1 to 5% of transplant recipients. It enters the human host by way of inhalation and can remain dormant for prolonged periods of time. Cryptococcus infection can spread to the CNS and bone hematogenously and often resembles a cold abscess similar to TB. The lumbar spine is most commonly affected, followed by the cervical region. Isolated cryptococcal osteomyelitis is rare, and bony lesions are seen in 5 to 10% of disseminated CNS cryptococcal infection. Blastomyces dermatitidis is found in the soil and infects humans by way of inhalation of conidia. It is endemic to the southeastern and south central states, especially those bordering the Mississippi and Ohio river basins. Unlike other fungal infections, blastomyces spreads through the bloodstream and can affect any organ months to years after the initial pulmonary infection. The skin is the most common site of extrapulmonary infection. Skeletal involvement, of which the spine is the most common site of infection, is seen in 14 to 60% of patients with disseminated infection. The lower thoracic and lumbar segments are affected most frequently, as in TB, with the anterior aspect of the vertebral body being involved first. Infection can spread through the intervertebral disc and along the anterior longitudinal ligament. It can also lead to psoas and other paravertebral abscesses. Coccidioides immitis is endemic to parts of the southwestern United States, including the San Joaquin Valley, as well as Central America and parts of South America. Humans are most commonly infected by inhalation of the spores and less commonly through abrasions of the skin. The primary focus of infection is typically in the lung, but in 0.5% of patients, the disease is disseminated. Skeletal involvement develops in 10 to 20% of those with disseminated disease, of which spinal involvement occurs in about 50%. The most frequent presentation has been described to be pain, followed by neurological compression. The thoracic and lumbar spine are most commonly affected, but apart from this, epidural and paravertebral abscesses can develop. Those at risk for development of disseminated disease include Filipinos, African Americans, pregnant women in their third trimester, children, and elderly people. Exophiala dermatidis is a saprophytic, thermophilic black yeast which is isolated from many environmental sources. It typically affects immunocompromised hosts and usually manifests as cutaneous or subcutaneous disease. Systemic infections, though rare, are associated with significant mortality and morbidity with neurotropic infections, whose prevalence is growing, having the worst outcome with a mortality rate of more than 90%. Melanin is considered the most important virulence factor as it interferes with microglial cells. It is particularly known to cause fatal infections of the nervous system in patients with an Asian background. The spine is the commonest site of fungal infections of the skeletal system, being affected in about 50% of patients. In fungal infections of the spine, the common initial symptom is localized pain, similar to TB. Rarely, they can present with neurological symptoms like spontaneous cord transection and sacral root necrosis. A high index of suspicion is needed to diagnose fungal infections. A history of previous fungemia, immunosuppression, diabetes, central venous catheterization, intravenous drug abuse, parenteral nutrition, myelosuppression, or implanted prosthetic devices places patients at a higher risk for fungal infections. The radiographic appearance of fungal infections of the spine is quite similar to that of the pyogenic causes of spinal osteomyelitis. Fungal infections are characterized by hypointensity on T1 weighted MRI, which is typical of many infectious processes. However, a lack of hyperintensity on T2 weighted MRI, which commonly occurs with pyogenic infections, can be seen. This lack of signal was thought to be the result of a depressed immune response in immunocompromised individuals. The lack of hyperintensity may also be the result of the absence of proteolytic enzymes. It may also represent the paramagnetic and ferromagnetic properties of the fungus itself, as seen in fungal sinusitis. Mycobacterium tuberculosis as well as blastomyces can form paraspinal masses. Radiographic changes of fungal infections of the spine mimic those of tubercular infections in that fungal infections tend to spare the disc space, involve the anterior vertebral body, and lead to the development of large soft tissue masses. However, they involve adjacent ribs and posterior elements and develop draining sinuses less frequently. Involvement of posterior elements is rare in pyogenic causes of spondylitis, but is characteristic of fungal and TB infections. Intramedullary fungus ball has been described with infection by the Fusarium species, and imaging studies reveal an intramedullary ring-enhancing lesion. The imaging characteristics of spinal TB and fungal infections are similar to those of a neoplastic lesion, and thus the clinical history must be closely correlated not only to differentiate between pyogenic and non-pyogenic causes of spondylitis, but also to distinguish the findings from a neoplasm. CT in patients with fungal osteomyelitis typically reveals hypodensities in the bone with small irregular bone islands, as opposed to the appearance of a metastatic tumor in which bone is completely replaced by tumor in larger segments. With many radiographic similarities between fungal and tubercular infections of the spine, it can be difficult to distinguish between these lesions for targeting therapy. Non-specific markers such as the white blood cell count, ESR, and CRP levels certainly help identify the possibility of an infectious process. There are various commercially available antibody tests that have shown varying degrees of success in differentiating fungal infections, but tissue diagnosis by histopathologic examination is the standard for establishing appropriate diagnosis. Treatment of an immunocompromised state or elimination of the factors that put patients at risk for the development of a fungal infection is the first step in the treatment of fungal infections of the spine. Antifungal therapy should be started simultaneously. Non-operative management is the mainstay of some fungal infections of the spine, but some pathogens are best treated by surgical intervention for evacuation of abscesses, resulting in higher clearance rates. Patients with spinal instability, neurological deficit, or sepsis are also best managed by operative treatment. The aims of surgical management in such conditions should include thorough debridement, decompression, restoration of spinal alignment, and correction of instability. Patients responding to antifungal agents usually have resolution of their back pain and frequently progress to spontaneous fusion. Amphotericin B is the first-line agent for many disseminated fungal infections. Many of those who suffer from disseminated fungal infections will require long-term antifungal therapy. Although amphotericin B therapy is potentially nephrotoxic, the lipid formulation of amphotericin B has demonstrated fewer side effects. Surgical debridement and treatment with amphotericin B, followed by a course of itraconazole, have resulted in successful outcomes in patients with fungal skeletal infections. Both itraconazole and voriconazole have also been used successfully as primary or add-on therapy after surgical debridement. Operative intervention is rarely needed in patients suffering from cryptococcus infections of the spine. However, all patients with such an infection should undergo lumbar puncture to rule out CNS involvement because of the high rate of CNS infections in patients with disseminated cryptococcosis. Treatment of cryptococcosis differs depending on the patient's HIV status. The first line of therapy for cryptococcosis is amphotericin B in conjunction with flucytosine and ultimately fluconazole. However, success has also been reported in non-immunocompromised and relatively immunocompromised patients with primary spinal osteomyelitis using fluconazole therapy alone. In patients with cryptococcal infections of bone and in those who are HIV positive, the addition of fluconazole therapy is initiated earlier in the course of treatment. Lifetime prophylaxis with fluconazole may depend on whether a patient's immunocompromised state can be corrected. Similarly, those undergoing highly active antiretroviral therapy for HIV should continue this treatment while receiving antifungal therapy. To conclude, TB remains in the top 10 leading causes of death, even above HIV/AIDS in sheer numbers, despite a 22% drop in mortality from tuberculosis between the years of 2000 to 2015. Spinal tuberculosis continues to be a significant cause of morbidity, particularly in the developing nations of Africa and Southeast Asia, despite the rapid strides made towards early diagnosis and management. Uncomplicated spinal tuberculosis is primarily a medical disorder treated entirely by multi-drug antitubercular chemotherapy. Surgery is an adjunct for the treatment of complications like neurological compression, instability, and deformity. Immune deficiency because of age, chronic medical ailments, and HIV/AIDS increase the risk of acquiring tuberculosis. The rising incidence of multi-drug resistant and extremely drug-resistant tuberculosis is a matter of global concern. All the member states of the World Health Organization and the United Nations have committed to fight the global TB epidemic with the End TB strategy in 2015. This has the milestones of reducing deaths due to tuberculosis by 90% and the incidence rate of tuberculosis by 80% by the year 2030.